Okay, so for this PowerPoint, we're going to talk about Unit 7, which focuses on HIV, anaphylaxis management, and types of immunity. So we're going to explore the immune system, normal functions, and how disorders like HIV or severe allergies disrupts our body's defenses. Here are your learning objectives for this PowerPoint. So going back to ANP, you should have a basic understanding of our immune system, but overall the immune system helps to prevent our body from outside pathogens like bacteria, viruses, and abnormal cells. It includes innate or non-specific and adaptive or specific responses and organs like the bone marrow, the thymus, which we talked about in endocrine, the spleen, and the lymph nodes. So we have a couple stages of our immune response. So our immune system will first identify something that is not itself. So this is your recognition stage. We have our macrophages, our dendritic cells, and other antigen-presenting cells. These patrol the tissues. They then recognize something like a protein or an antigen that is an invader, and they alert those helper T cells to come to the spot. So these are kind of like the security guards that spot an intruder and call headquarters. Then we have our second stage, our proliferation. This is our activation stage. Once those T helper cells sound the alarm, then we have our T cells and our B cells that start multiplying rapidly. This helps to build up that army that helps to invade or attack the particular antigen or invader that's occurring. So this is basically like headquarters calls in reinforcements. Those T cells and B cells start activating and start to proliferate or rapidly increase or keep multiplying to build up more soldiers. Then we have our response. So stage 3 is a response. This is where we have a two-pronged attack. So we first have the cell-mediated response. So the T cells directly start attacking infected cells. Okay, so we directly attack. Then we have our humoral response for our B cells. Our B cells then become plasma cells to help produce antibodies, which help to neutralize the invaders. So basically, we have a two-level attack. T cells directly attack the cells from the ground, and the humoral response, those B cells produce antibodies, which help neutralize the invaders, kind of like an airstrike. Then we have the fourth stage, which is the effector stage. So this is where the antibodies are able to neutralize the pathogen, and killer T cells help to destroy those infected cells. The infection is then cleared up. So then the cleaning crew comes in, which are your phagocytes. This helps to remove debris and inflammation starts to subside. So the battle is over, everybody stands down, and those phagocytes start to come in and clean up the dead bodies all over the ground. Now we have our memory stage. This is where our B cells and some T cells become memory cells, so that if that same antigen returns, that immune system is faster and stronger. They're ready for that attack because they're used to whatever antigen came into the body. So this is how our immune system responds to antigens outside of the body and develops a immune response for future attacks. Okay, so our body has a couple different types of immunity. The first one we're going to talk about is innate immunity. So innate immunity is our body's built-in defense system. It's always on. It's the first line of protection that we're born with. And it basically reacts the same way to any invader that comes in. So a bacterial infection enters our body, we're going to act the same way as if a viral infection came into our body. So it's non-specific. It's the first line of protection. Oftentimes with our innate immunity, we have our immediate response. This usually kicks in with minutes to hours. Then we have no memory, so it doesn't learn from past infections. Every single encounter gets the same reaction. Kind of has a broad protection, so these patterns of reaction kind of are common to most microbes, and there's not a unique response. We have an instant, fast, and general reaction. So innate equals instant. It's always on, and it's usually on duty before our adaptive special forces arrive. On the other hand, we have adaptive immunity. So adaptive immunity is specific and it is a learned defense system of the body. So unlike innate immunity, adaptive immunity targets a particular pathogen with a customized attack. It creates long-term memory, so when that antigen or pathogen enters the body again, it has a faster, stronger response. Key features of this are that it has specificity, good grief, where it can recognize unique antigens on each microbe. It creates a memory, so after that first encounter, those memory cells remember the antigen and help give it long-lasting protection. It is a little slower to start, so it can take days after the first exposure to get a full response. So your innate immunity or innate inflammatory response kicks in first, and uh, the adaptive immunity will come in second. So again, adaptive immunity is the body's kind of tailor-made long-term protection. Takes a longer time to suit up for the battle, but once it gets there, then it remains memorable for years. So it'll have that immunity for longer periods of time. So we have some different factors that can impact our immune function. So one thing is age. So our immune system is very immature early on. And so as infants and children, we rely on antibodies from things like early vaccines or breast milk. Our older adult population has a heavier natural immune system because they've been exposed to things, but they have a little bit weaker of protection through vaccine protection as well. They typically also have a slower response and fewer T and B cells. Nutrition can also impact our immunity. So proteins and vitamins like A, C, and E are building blocks for those immune systems or immune cells. So if we have decreased protein or malnutrition, we maybe have decreased vitamin A, C, and E, then we might have a decrease in our immune system. We also have changes in our hydration status. This can help support our lymphatic flow and help circulation. So if we're dehydrated, we may not have enough hydration to circulate fighter cells, T and B cells, and things like that throughout our immune system. Then we have stress. Stress can definitely lead to decreased immunity, especially our chronic stress. So chronic stress keeps cortisol levels elevated, which suppresses that white blood cell activity and inflammation control. So we really want to make sure that we educate on stress reduction techniques. Sleep is another risk factor or another factor that contributes to immune systems. So if our patient's getting less than 6 hours of quality sleep, it actually can reduce our NK cells from functioning. We want to encourage consistent sleep patterns for our patients and remind them that they need to sleep consistently. So they should be sleeping. It is recommended 8 hours every night. Although as a nursing student, we know we're barely getting 4 if we're lucky. Okay, so try to sleep as much as possible. Another one is exercise. So exercising helps to boost circulation and helps with immune surveillance. So we want to make sure that we do moderately light to moderate exercise regularly. They say about 30 minutes every day is recommended. Chronic illness and medications can decrease our immune response. So chronic illnesses like diabetes, kidney disease, HIV, and cancer all weaken that immune response. And so that can lead to a decrease in our immune system. We also can have steroids or chemotherapies or immunosuppressants that intentionally dampen down immunity, right? So we want that to occur, but that decreases our immune function. So make sure for patients who have chronic illnesses that decrease immune responses or medications that are immunosuppressants, we want to make sure that we continuously monitor for infection, teach good hygiene like hand washing and cleaning, and report symptoms of infection. Then we have environment and lifestyle, so things like smoking, alcohol, or repeated exposure to pathogens like pollutants or carcinogens can decrease our immune system as well. Then we have genetics. So sometimes our family history or our genetic component can increase or decrease our immune system. Those would be things like autoimmune disorders or immune deficiency disorders. Okay, so now we're going to talk about HIV. So HIV is a virus that attacks the immune system, specifically the CD4 T helper cells, which is the command center of our adaptive immunity. If we don't treat it over time, it weakens the body's ability to fight infections and certain cancers and can lead to AIDS, which is acquired immunodeficiency syndrome. HIV is transmitted through a couple different ways. The main one is through blood and body fluids. So this is through sharing needles, blood transfusions that are not screened. This is rare today since most blood transfusions are screened for diseases, HIV, things like that, but it still can happen. Unprotected sexual conduct, blood exposure, so needle sticks or exposure to blood with nursing staff or healthcare professionals can get HIV. Mother to child during pregnancy, birth, or breastfeeding if the mother is untreated, and then any type of blood or body exposure. It is not spread by casual contact, such as hugging, sharing dishes, or insect bites, or things like that. So we want to educate our patients on preventing exposure through safe sex practices, harm reduction like needle exposure or sharing needles. We want them to get clean needles if they're going to do drugs. Making sure that we educate them on prenatal care and exposure through that. So some basic pathophysiology for HIV has to do with the way that it enters the body and how it replicates and decreases our immune system. So HIV enters into the body through blood exposure or body fluid exposure or pregnancy. And that HIV attaches to the CD4 cells and enters into them. Once it's inside, it turns its RNA into DNA and actually reverse transcribes and integrates into the host genome. The cell then replicates and infects the new cell to make new viruses, which spreads to more CD4 cells. Over time, those CD4 counts drop, which leads to the body being open to opportunistic infections, and that immune system declines. So when we're looking at our patient's HIV, we want to look at their viral load and we look at their CD4 counts to see if they are, having a really bad HIV infection versus a manageable infection that maybe has lower viral counts. For your stages of infection, we have the acute infection. This is usually 2 to 4 weeks after exposure. Patient Qs will have flu-like symptoms. So they may be lethargic, fevers, kind of a general feeling of malaise, and then their viral load would be high. They would have a high viral load count. We then have our clinical latency or our chronic HIV stage. This can last many years. They oftentimes will have a few symptoms, but mainly this is where the virus keeps replicating. Then we have stage 3, our late stage. This is where we diagnose it with AIDS. This is often a CD4 count of less than 200 or a diagnosis of an opportunistic infection. So that would be something like pseudocystitis pneumonia or Kaposi sarcoma. So for treatment of our HIV or AIDS, we do antiretroviral therapy, also known as ART therapy. This is a combination of drugs that help to suppress the virus and help to let the immune system recover. Now, these are classified into NRTIs and NRTIs, protease inhibitors, or integrase inhibitors. Oftentimes, these antiretroviral medications can be very taxing on the body, so they can have a lot of GI upset. They can cause a lot of exhaustion in our patients, but adherence is critical to prevent resistance to these medications. And if we get them on a good ART therapy, it can actually decrease the viral load to where that viral load is undetectable. So this means that that virus is untransmittable when it's maintained. So that's our goal for ART therapy, is to have an undetectable viral load, which means we're not transmitting it to others. And we want to prevent resistance to the medication. For our nursing interventions, make sure that we have education for medication adherence. This helps to decrease drug resistance and helps get that viral load as low as possible. We want to monitor the CD4 counts and viral loads regularly to make sure that we are moving in the right direction with our medication adherence. Educating on safe sex practices, harm reduction strategies like clean needles, or PrEP, which is the post-exposure preventative treatment for partners that may come into contact with that. Same thing with nurses. So let's say you have a needle stick and it's a patient who may or may not have HIV. You may take the PEP medication. So first step is to remain calm. Make sure you clean the area with soap and water. Make sure you notify your staff, your charge nurse, the floor nurse, the nurse that, your manager, or if you're a student, notify your clinical instructor, and then they may refer you to testing. And depending on the exposure risk, you may want to do the PEP medication. When you take the PEP medication, you're going to take antiretrovirals. Usually you take it for a couple weeks, and then you'll do testing. So you usually do blood testing to see if you have any HIV, labs or antibodies in there in your blood. And you'll usually do testing, initially, then after 1 week, after a month, after 6 months, after 8 months. You'll do frequent testing all the way up until a year. So just keep in mind that that's post-exposure for you as nursing students or a nurse at bedside as well. Okay, so we're going to talk about anaphylaxis. So anaphylaxis is a life-threatening, rapid onset allergic reaction. It is a type 1 hypersensitivity reaction, which means the immune system overreacts to an allergen, something like a food, medication, or a bee sting, and it releases a flood of chemicals, especially histamines. Histamines cause widespread inflammation and can lead to shock in our patient. Common triggers are food allergies like peanuts, shellfish, and tree nuts, insect stings like bees, wasps, or scorpion stings, latex allergies, and medications like antibiotics such as penicillins, contrast dye, and NSAIDs. So this is why it's really important to get allergy lists for your patients before you give them any medications, expose them into any latex with Foley's or anything like that, or medication. A brief how it happens, pathophysiology for anaphylaxis is our first step, which is the exposure to an allergen. So when an individual is exposed to an allergen like peanuts or latex, This causes the body to make IgE antibodies. Once the patient is exposed again to a second exposure, allergens bind to those IgE antibodies on the mast cells and the basophils. These cells degranulate and release histamines, and other mediators. This results in a massive vasodilation and capillary leak and can lead to bronchoconstrictions. So our airway swells up and closes off. We have massive vasodilation, which leads to a huge drop in blood pressure, and our capillary leak starts leaking out all of our fluid inside of our vascular space. So we have a potential cardiovascular collapse. Patient cues that you'll see with anaphylaxis. These often appear within seconds to minutes after exposure from that antigen. In our skin, we might see giant hives or welts, itching, severe flushing or redness, or we may have or see angioedema. This is a swelling of the lips or the tongue. The respiratory system will start having wheezing, a throat tightness or closing of the airway, shortness of breath, and you may hear stridor. So make sure you go listen to an example of stridor on YouTube, because that is the air going through a narrow opening, like their narrow constricting throat. Anytime you hear stridor, medical emergency. You need to rush and get some help. Cardiovascular system, you're going to have hypotension due to that huge vasodilation. They may have a rapid pulse because our cardiac system beefs up the pulse to try to compensate for that low blood pressure. And we might have dizziness. Eventually, your patient's going to go into shock, so we need to give fluids right away. Our gastrointestinal system starts to also have effects. You might see nausea, vomiting, diarrhea, or cramping. Okay, so A, B, C, the rest of it. This is really important in your nursing priorities for anaphylactic reaction. So first thing is to call for help. You're going to want more hands in the pot because you're going to have a collapse and a problem with multiple different areas of your patient. So get some help, call a rapid response, activate your emergency response system. Then we're going to do our A's. You want to maintain your airway. So you need to make sure to give high flow oxygen because that tube that's your trachea starts to close off. So you've got to high flow that oxygen in there so that it's able to get through that narrow opening. You might want to prepare for a possible intubation if that airway is closing off completely. They've got to get that airway open. Elevate the head of the bed, give them some oxygen. Then what you want to do is you want to give them epinephrine. So that's a medication that is used to open up that airway and vasoconstrict. This is a first line medication. Oftentimes it's given in the mid to outer thigh as soon as that anaphylaxis is suspected. With our positioning, if our breathing is easier upright, you're going to leave them sitting up. You also can place them in a supine position with the legs elevated. That helps get circulation towards the vital organs, okay? Because they're going to start to vasoconstrict, and all their blood is going to leave their extremities and start going to their vital organs. So it'll go to their core. Then we want to support circulation. So we need IV fluids for that hypotension, because remember, we're at the C. We did the A, we did the B, now we're doing the C. So IV fluids for hypotension, probably going to do a normal saline, 0.9% normal saline fluid bolus, okay? Then we're going to give some medications that help to be an adjunct to that epinephrine. So we're probably going to give some diphenhydramine or Benadryl, which helps with antihistamines, so it helps decrease those. Then we're probably going to give some corticosteroids that helps with inflammation and swelling of the airway. Then we're probably going to give some bronchodilators to help open up the airway and dilate the bronchioles. So that's given after epinephrine. So epinephrine to open, bronchodilators to dilate. So our nursing interventions: recognize an anaphylactic reaction, call for help to get more people involved, um, do your ABCDs, and then you're going to monitor. You're going to evaluate and monitor. So we want to monitor for biphasic reaction, which is symptoms returning hours later. So this can occur in your patient. So monitor their vitals, monitor their airway, continue keeping an eye on them. Identify and document the allergen. So try to figure out what was the trigger in your patient. Educate them on avoiding that allergen and using possibly an EpiPen or an auto injector. Um, Teach them how to carry it, how to use it, how to store it. They also may want to use a medical alert bracelet, so educate them or encourage them to wear a medical alert bracelet. So A, B, C, D, E's. So A is airway, B is breathing, circulation is C, D is the rest of it doesn't matter, and E, epinephrine first. So it's a medical emergency.